Yeah, hi.
Hello,
Yeah,
sir.
hi. Okay,
Yeah,
let me start.
yeah.
Hello, good evening, and a warm welcome to the Chief Guest of for honor today, Dr. Shabana, all the audience for this VDC Clinical Radiological. I'm Dr. Vijayanand, and I'm Senior Consultant Radiologist at Vijaya Diagnostic Center, and I'll be the moderator for today. I think I'll be the one who'll be getting maximum benefit today because this is one of the area of interest I like. So probably I'll go with maximum knowledge from here. So as we see every day as doctors, we see a lot of patients coming with history of back pain, joint pains, muscle pain, and so many other things. And it looks very simple that way. But if we try to dig deep into the subject, we come out with a huge spectrum of back pain or back pain causes, especially spondyloarthritis, which which we'll be talking about today. So we'll be limiting ourselves to the seronegative spondyloarthropathy as because if we try to go deep into seropositive and seronegativity, both are a huge topic and it takes a couple of days to complete them. So limiting ourselves to the seronegative spondyloarthropathies, uh, I think we'll move ahead today. And to discuss this, we have with us Chief Guest of Honor today, Dr. Jugal Kishore Kadel. Uh, Let me introduce to him. He is a clinical director and a senior consultant rheumatologist at Gachibowli AIG Hospital. He's also worked in a few of the prestigious hospitals like KIMS Hospital, Hyderabad, and Care Hospitals, also Nizam's Hospital. He's completed his MBBS from Kakatiya Medical College, Warangal, and DNB from Usmania Medical College, Hyderabad. Other than this, he has also undergone a lot of training programs. Few of the notable ones are advanced training in osteoporosis, Lyon, France, which was organized by the International Osteoporosis Foundation, and another being a fellowship in pediatric rheumatology from GENOA Gaslini Institute, GENOA, Italy. He's also one of the principal investigator for more than 30 global clinical research trials in rheumatoid arthritis, ankylosing spondylosis, and SLE. And he's also a member of multiple professional associations like Indian Medical Association, Indian Rheumatology Association, American College of Rheumatology, Pediatric Rheumatology International Trial Organization, Italy, and the Pediatric Rheumatology European Society. Uh, we are glad that we have you on board today. Welcome you
Thank
on
you.
board.
Thank you, sir.
And yeah, and the next speaker is Dr. Shabana. She's a very own working in Vijaya Diagnostic Center, consultant radiologist. She'll be speaking today on the spondyloarthropathies, as I already told you. But her main area of interest is also abdominal imaging and fetal imaging. So, before we go deep into the radiology discussions, I would also like to tell the audience that we have a chat box here. If anybody, any audience, maybe doctors or non-doctors, anybody who are listening can just write down the queries in the chat box, and we have the panelists who are here to solve those things for you. So, uh, before going into the radiology part, I'd request Dr. Jugal Kishore to share his experience and his clinical perspective regarding these spondyloarthropathies, wherein the patients daily come in with the history of all the clinical symptoms I already mentioned. Over to you, sir.
Yeah, thank you, sir. Good evening, good afternoon, everyone. As you know, we are going to have a discussion about the spondyloarthropathies. It's a broad spectrum of diseases which comprises uh, many systemic diseases which involves predominantly the axial skeleton as well as the peripheral skeleton. So spondyloarthropathy predominantly have the patients who comes with spondyloarthropathy. Clinically, they present with either the backache or they can have neck pain, they can have pain in the buttocks, or they can have pain in the lower extremities where the tendons or ligaments get inserted, which we call as enthesitis. So patients can have various presentation. Patient can have the involvement of the extra articular organs like eyes, where they can present as episcleritis, scleritis, uveitis. and patient can have the involvement of the gut where they can present as IBD. In IBD, we have two diseases like Crohn's and ulcerative colitis, where the patient comes with abdominal pain, diarrhea, or they can have bleeding per rectum. So, patient can present with these diseases when they have a extraarticular manifestation in various other specialties rather than landing with the orthopedicians or a rheumatologist. One spectrum of the patient can have a skin manifestation in the form of psoriasis, where they will be treated by a dermatologist. Patient may not have initially the involvement of the joints. So, how broadly we differentiate whether the patient has a inflammatory disease or it's a mechanical disease or non-inflammatory disease? So, we have certain criteria, which is called as the criteria for the inflammatory backache. Where onset of age, they can have the morning stiffness, and usually the pain relieves the stiffness or the activity relieves the pain or the stiffness, whereas the rest makes it more worse. And they can have other organ involvements also. So once the patient comes with this, then we evaluate. We do certain serology, we do radiology, where we can go for X-rays, we can go for MRIs, and we can go for nuclear bone scan also when you are clinically you are not able to appreciate much clinically, but you want to know whether the patient has involvement of enthesitis or the patient has mild disease, where they can be picked up by a test called nuclear bone scan, or you can do the MRIs also to pick up whether they have the sacroiliac joints or facet joints involvement.
Okay. Okay. Thank you so much, Dr. Jugal Kishore.
Yeah,
Now we'll be going to the radiology part, and once Dr. Shabana completes her talk, or else you probably if you want to interrupt her somewhere and you want to clear the doubt somewhere, or you have some queries where we can discuss and clarify that is also okay. Uh, Anyhow, like once Dr. Shabana completes, we can have a small discussion regarding the spondyloarthropathies and try to come up with some good solutions regarding the patient queries and maybe our doctor's queries also. Dr.
definitely.
Shabana, over to you.
Good afternoon, everybody. So, discussing the spondyloarthropathy. Spondyloarthropathy usually is the term reserved for seronegative inflammatory joint disease. That means it is HLA-B27 positive and negative for rheumatoid factor. In this in this inflammatory joint diseases, we see predominant involvement of axial skeleton, including SI joints and vertebral column, with peripheral manifestations like what Sir said, that is enthesitis. Enthesitis is the one which is inflammation of the involved attachments of the tendons, ligaments, or capsules to the bone, and also there is involvement of the peripheral joints. These group of seronegative inflammatory joint diseases include ankylosing spondylitis, which is the largest subgroup, psoriatic arthritis, reactive arthritis, enteropathic arthritis associated with inflammatory bowel diseases, undifferentiated spondyloarthropathy, and juvenile spondyloarthropathy, which is seen in of less than 16 years age group of people. The modern concept of classification has been divided as axial and peripheral spondyloarthropathy. So, if we just go briefly into the pathophysiology, it is either the antigen or infective source which is causing the inflammation, leading to marrow edema, resulting in subchondral sclerosis, which heals by newborn formation. And the places where there is enthesitis, there is high level of metabolic activity with abundant nerve supply, which leads to inflammatory pain. So, like what Sir said, the criteria of inflammatory back pain is different from the mechanical back pain. Inflammatory back pain usually is associated with morning stiffness of more than 30 minutes, and patient usually complains of back pain of more than 3 months duration. And this pain is not relieved with rest. It is improved with exercise, in fact. And patients even complain of buttock pain, which is on either side. And patients usually wake up in the midnight because of this pain. So these are the criteria which differentiates inflammatory back pain from the mechanical back pain. So classification based on the Association of Spondyloarthropathy International Society for axial and peripheral has been categorized separately. So for axial spondyloarthropathy, the patients who complain with back pain of more than 3 months with age of onset of less than 45 years, we have to consider these particular things. The sacroiliitis on imaging with one of these spondyloarthropathic feature. These features include either inflammatory back pain, arthritis, uveitis, dactylitis, psoriasis, or associated inflammatory bowel disease, and patients usually show good response to NSAIDs. Any family history of spondyloarthropathy, HLA-B27 positive with elevated CRP. Any one feature with sacroiliitis positive on imaging has been classified into the criteria for axial spondyloarthropathy. Otherwise, it could be either HLA-B27 positive with any either two of these features. Coming to the peripheral spondyloarthropathy, it could be either arthritis, enthesitis, or dactylitis with any one of these feature, including psoriasis, IBD, infections, HLA-B27 positive, uveitis with positive radiograph or MRI for sacroiliitis, or apart from this, these two with arthritis, enthesitis, or dactylitis, including arthritis, IBP in the past, or positive family history of spondyloarthropathy. So the peripheral arthritis is usually, it can be usually it is usually asymmetric, involving unilateral or bilaterally. So coming to the imaging modalities, MRI is more useful in early diagnosis. X-rays are not useful in early diagnosis because the images on radiographs show very late presentation of the changes that happens in the bone. Coming to the various modalities, if you see the radiographs help in monitoring changes in the spine, syndesmophytes, which are very clearly seen on X-rays, spinal fractures, newborn formation, and X-rays of hand and feet, especially in psoriasis and reactive arthritis. CT. CT can be used to replace radiographs. Low-dose CTs can be used to replace radiographs for monitoring changes. And CT is gold standard for seeing the structural damages in side joints, chronic changes, and the fractures which we tend to miss on X-rays, and identification of syndesmophytes or paradesmophytes. MRI. MRI is very useful in early diagnosis of seronegative spondyloarthropathy. Acute inflammation is very well picked up on MRI, and young patients whom we don't want to subject to more radiation, MRI is useful. And peripheral spondyloarthropathy, there is more involvement of soft tissues. So it helps in picking up the lesions in a better way. Ultrasound is useful to see this bursitis, enthesitis, and synovitis. Uh, DXS scans can be helped to rule out to see any osteoporosis in the hip or spine. Scintigraphies can be useful, but they are less sensitive than MRI. So coming to the major spectrum involved in the seronegative spondyloarthropathy, ankylosing spondylosis, which is a very common spondyloarthropathy. Common sites of involvement include SI joints, DL spine, LS spine. Peripheral joints involvement can be seen in hips, shoulders, and in lower limbs, it's more in asymmetric fashion. Enthesitis is more in the lower limb tendons. If you see the other systemic features like what Sir said, it could be anterior uveitis, scleritis, episcleritis, upper limb pulmonary fibrosis with cavitary changes, and cardiac valvular involvement, especially aortic valve abnormalities, are common findings. Now coming to the images, imagiology, SI joints. Uh, so usually it is a bilateral symmetric sacroiliitis. Erosive changes leads to reactive sclerosis, resulting in osseous ankylosis. These are the series of events that happen in sacroiliitis in the ankylosing spondylosis. Initially, the erosions causes pseudo widening, so it can result in mild widening of the joint space. Later, later to it, the erosions result in sclerosis of the joints, and finally, there is a fusion. So the erosive appearance, the various appearances on X-rays which can be seen, like erosive appearances on the SI joints can be seen as a beady appearance because of irregularity on the irregular margins of the joint spaces. Usually the fusion and ankylosis is more early seen in the superior aspect of the SI joint. When there is complete fusion of the joint, there is no joint visible. There is a thin sclerotic line seen along the joint space that is called as ghost joint. Coming to the X-rays and MRI of the spine, there is a squaring of the vertebra completely, and there is ossification of the supraspinous ligament, which results in the appearance of a dagger known as dagger spine. There is continuous flowing of ossification seen along the anterior margin of the vertebrae known as syndesmophytes, which are more vertical, seen contiguously involving more than 4 vertebral bodies. And the other lesions which are very important, most commonly seen in the ankylosing spondylosis is Romanes lesion. This is the margin of enthesitis. This is the involving the insertion of annular fibers and in the anterior and superior aspect of the vertebral bodies. And Anderson lesions are the involvement of, this is the non-inflammatory involvement of the intervertebral disc along the end plate margins, commonly seen in the seronegative spondyloarthropathy, especially in the ankylosing spondylosis. So the Romanes lesion on X-ray is seen as sclerotic margin known as shiny corner. There is associated enthesopathy and viscering of the joints, resulting in complete fusion of the joints, predominantly hip joints and the lower limb joints. Take the X-ray of the shoulder, even the enthesopathy can involve the rotatory cuff muscles, resulting in irregular margin of the tuberosity known as Hatchett sign. These are the MR images depicting the marrow edema on the either side and erosive changes along the iliac margins of the sacroiliac joint. So usually in ankylosing spondylosis, it is more symmetrical, bilateral, involving the iliac margin on the earlier end. So this is the CT images showing the complete fusion of the bilateral SI joints. There is this is the involvement of the costovertebral joint where there is complete fusion. And this is the late sagittal image of the spine showing syndesmophytes and fusion of the posterior elements, typically showing the appearance of the bamboo spine. Next, coming to the psoriatic spondyloarthropathy. This is an inflammatory arthritis usually seen in people with psoriasis. 10 to 15% of people with psoriasis, usually people present with cutaneous rashes initially, and this can lead, it may take months or years to depict as arthropathy, or it can be a reverse order. More commonly seen in females, it is associated with HLA-B27. These can be seen as a spectrum of three. It can be monoarthritis or oligoarthritis with enthesitis, or it can present as symmetric polyarthritis like rheumatoid arthritis, or it can be an axial disease like ankylosing spondylosis without peripheral joint disease. So more commonly, it is asymmetric, either unilateral or bilateral, involving synovium, cartilaginous joints, and enthesitis and non-marginal desmophytes are more commonly seen. More commonly involves the hand and feet joints. Uh, Distal interphalangeal joint and proximal interphalangeal joints are the commonest joints to be involved in the hands, and metatarsophalangeal joint in the foot. Involvement of knee and ankle is also seen. Sacroiliitis is less common, but if it is associated, it is seen as asymmetrical or unilateral, not bilateral like ankylosing spondylosis. Usually, if sacroiliitis is present, small joints of hand and feet are involved, sacroiliitis can be associated with it. Spondylitis is common if sacroiliitis is also present. So distal interphalangeal joints are frequently involved in the hands. So we see as the presence of erosions, resorption of terminal phalanges, associated sacroiliitis or interphalangeal joints of the grade 2 involvement with arthritis and bone loss occurring mainly in the digits. So if we take the psoriatic arthritis, the typical appearance of dactylitis on radiographs is seen as a swelling in the entire digit. So the continuous involvement of distal interphalangeal and proximal interphalangeal joints with inflammation of the synovium and tenosynovium results in marked deformity of the fingers, resulting in dactylitis. Other features we can see in psoriatic arthritis is penicillin cup deformity, osteolysis of and ankylosis of the joints, and sometimes we can see there is periosteal and endosteal bone formation involving the entire phalanx, known as ivory phalanx. So, compared to the ankylosing spondylosis, the syndesmophytes, known as parasyndesmophytes, are different from ankylosing spondylosis in the way that they are not continuous; they are asymmetric. They don't follow all the vertebrae. They can be like few vertebrae can be not normal and few can be spare. The para associated with ankylosing spondylosis are more continuous, which results in bamboo spine appearance, which is not seen in psoriatic arthritis because the syndesmophytes or paradesmophytes seen in this are not continuously involving the spine. And usually the cervical spine involvement is more commonly seen in psoriatic arthropathy when compared to the ankylosing spondylosis. And all the features of erosion, syndesmophyte formation, and calcification are all typically seen in cervical spine if it is if psoriatic arthritis is involving the cervical spine. These are few of the X-rays which show the erosions which are more frayed. Erosions are more frayed due to periarthritis, and more commonly the recessive changes are seen in the distal interphalangeal and the proximal interphalangeal joints, and there is typical sparing of the metacarpophalangeal joints and the wrist region. Marginal erosions are very commonly seen with fluffy bone formation adjacent to the marginal erosions. So this is the image showing a penicillin cup deformity at the distal interphalangeal joint, where there is a irregularity of the distal end of the middle phalanx, which resembles a pencil-like appearance, and this is the cup formation in the proximal end of the distal joint. This is the typical appearance of the penicillin cup deformity. And involvement of the distal interphalangeal joint is the one which typically differentiates from the rheumatoid arthritis. And there is typical ray-like pattern of involvement. That is, all the joints are sequentially involved, which results in sausage or spindle-shaped digits in psoriatic arthritis. So if you go to the imagiology, apart from X-rays, CT can be used for sacroiliitis, MRI for soft tissue edema, and involvement of soft tissues, ultrasound to rule out joint effusions and tendinopathy, the synovial thickening that happens around the joints. Scintigraphy can be also used to see any asymmetric uptake in the region of inflammation of synovitis or tenosynovitis. So the next spondyloarthropathy in this group is Retter's spondyloarthropathy. So this presents with triad of conjunctivitis, non-gonococcal urethritis, gastroenteritis. It is due to the acquired infectious agent either chlamydia, shigella, salmonella, or Yersinia, which is followed by arthritis after 1 to 4 weeks of interval. Majority of these people show HLA-B27 positive, and if you see the clinical picture, because of gastroenteritis and infectious etiology, we see fever, weight loss, patients present with painless oral ulcers, diarrhea, cervicitis, or prostatitis, and if you see the involvement of joints here, it is more kind of oligoarthritis of large synovial joints of the lower extremities. Imaging features typically is unifocal or multifocal in a single region rather than panarthritis. That means a single joint may be severely destroyed and the adjacent joint may be normal in this Ritter's arthritis. Associated inflammation of the digits is common. SI joint inflammation also can be seen. Predominantly erosive changes of the joints with periostitis and enthesis are the characteristic feature. If you see the radiographic involvement, if you see the distal lower limb involvement, it's predominantly seen in the foot region, in the calcaneum, at the MTP joints, and even ankle and knee joints can be involved. If you see the calcaneum, it is more seen as reactive spurs, painful erosions at the plantar aponeurosis site. Achilles tendinitis also can happen where there is inflammation of the insertion of tendon of Achilles, retrocalcaneal bursitis, marginal erosions. There is bony proliferation at sacroiliac joint. Usually it is unilateral and asymmetric initially in readers, and later it can progress to bilateral with ankylosis. So here we see parasyndesmophytes, which are more coarser, thicker, more in thoracic spine with discontinuous spondylitis. So few images to show the reader's arthritis changes. This is the X-ray which shows reactive arthritis. Here the second and third MTP joints show erosive changes with bone proliferation, and there is new bone formation in the distal end of the metacarpals. This is the ultrasound image showing changes of inflammation, synovial thickening, just beneath the Achilles tendon. This is the ultrasound of the finger, which shows. This is the ultrasound of the foot, which shows second MTP joint, where there is a focal proliferation of the synovium, which is very commonly seen in the reactive spondyloarthropathy. This is the X-ray, which shows reactive enthesitis at insertion of tendoachilles and regular vertic spur in the base of the calcaneum. MR also helps in picking up the lesions. This is the PD FATSAT image showing bulky tendon of Achilles with hyperintense signal in it, and there is loss of the normal concavity of the anterior margin of the Achilles tendon. This is a site of pain of the patient, and there is significant changes seen in the Achilles tendinopathy. Next, coming to the enteric arthropathy, this is usually associated with Crohn's more than ulcerative colitis, other gut infections, even Whipple's also. The risk factors include active bowel disease, family history of inflammatory bowel disease, smoking, history of appendicectomy, or other extraintestinal manifestations. Arthropathy, this is usually axial, more commonly associated with HLA-B27. Here we see symmetrical and bilateral involvement of SI joints like in ankylosing spondylosis. When there is a peripheral arthritis, it is more non-erosive and non-deforming. So these are few of the images showing changes in the bowel, transmural enhancement. This is MR angiography showing transmural enhancement of the ileal loops associated with bilateral symmetrical sacroiliitis. And this is a CT image showing the similar findings, sacroiliitis with transmural edema with thickening of the bowel loops. So undifferentiated, there's other group called undifferentiated spondyloarthropathy. This group includes the spondyloarthropathy which is not fulfilling the criteria whatever we discussed before, but usually these people usually tend to progress into ankylosing spondylosis. Lesser group of people, they can tend to progress to psoriatic or reactive arthropathy. And for undifferentiated spondyloarthropathy, MRA is very useful in which helps in monitoring the disease progression. There is another group of juvenile spondyloarthropathy, commonly seen in less than 16 years, positive. So here we see more peripheral arthropathy, which is persistent and non-destructive. In juvenile spondyloarthropathy, erosions are very rare, and tarsitis and enthesitis of lower limb is very commonly seen. So here we see the spectrum of ankylosing spondylosis, psoriasis, reactive arthritis, and inflammatory bowel disease kind of arthritis, even in the younger group of people. If we take the ankylosing spondylosis in juvenile group of people, Usually the SI joint involvement is unilateral when compared to the adult where there is bilateral involvement. Involvement of the first MTP joint, interphalangeal joint is common, and sternoclavicular joint involvement is also commonly seen in juvenile ankylosing spondylosis. Juvenile psoriasis has got more peripheral and symmetrical involvement, predominantly involving the distal interphalangeal joints, and acroosteolysis like picture is also seen. Reactive arthritis is a little rare in the juvenile group of people. Inflammatory bowel disease arthritis has more of osteoporotic changes in the larger joints with associated enthesitis. This is just to differentiate between the adult and juvenile group of spondyloarthropathy group. So coming to the differentials, so it can be confusing because sacroiliac joint involvement can be seen with other things also. So uh, if you see, there's an entity called osteitis condensus ili, which is more common in women. And here we see there is a symmetrical triangular shaped of sclerosis, which is more commonly seen in the antero-inferior iliac margin. Here, the key feature is the joint space is relatively preserved and there is no erosive changes. And septic arthritis can be one of the differential, especially for the hand and foot arthritis, where there is more of soft tissue involvement. Degenerative arthritis also can be superimposed. So, to differentiate between osteophytes and syndesmophytes, osteophytes are more horizontal and they're associated with sclerosis and degeneration when compared to the syndesmophytes, which are more vertical and flowing, and they are continuous, at least involving more than four vertebra. So this is the way how we differentiate between the syndesmophytes and osteophytes. And degenerative arthritis can also be differentiated with associated subchondral cysts and significant joint space narrowing. So the other changes like modic changes which happen in degenerative spine can should be differentiated from the Anderson lesion. Usually type 1 and type 2 Anderson lesions, type 1 and type 2 modic changes should be differentiated from Anderson lesions. Modic changes are commonly associated with disc degeneration. Anderson lesions are not associated with disc degenerative changes and they are usually associated with sacroiliitis and other features of inflammatory spondyloarthropathy. The other entity which should be ruled out from the seronegative spondyloarthropathy is dished, where there is flowing ossification along the anterolateral aspect of the vertebra. And dish usually do not involve the sacroiliac joint, costovertebral facets, sclerosis or erosions, as we saw in the images that I showed you in the ankylosing spondylosis. So, infective spondylodiscitis also can be close differential, but here we usually see the involvement of disc and end plate with epidural and paravertebral soft tissue lesions, which is not seen in the Anderson lesion of the seronegative spondyloarthropathy, which helps in differentiation.
Yes. Thank you, Dr. Shabana. It
Yes,
was a
sir.
great presentation. Uh, Dr. Kishore, do you have any questions or any additions to be added to this?
It's me.
Yeah. Do you have anything extra you want to add to this, like correlating with the clinical scenario with the MRI explanation or radiological
Yeah.
explanation? What?
Uh, Suppose from the clinical perspective, somebody is presenting with predominantly lower joint involvement. Somebody is having asymmetrical involvement. Patients having the pain in the heel or patient having pain in various abnormal sites like outer side or inner side of the knees or the thighs. So that can be because of the enthesitis. So when should you have the high index of suspicion? It could be spondyloarthropathy. It is asymmetrical arthritis, young patient, even if the lab parameters are negative, in the patient's family there is a history of spondyloarthropathy in the form of psoriasis or HLA-bitonism positivity or IBD, then we should rule out spondyloarthropathy in that subset of patients. Sometimes patient comes with a vague aches and pains. They say they have backache. We are not able to appreciate it even on radiographs. Also, they may not have obvious synovitis or peripheral arthritis. But patient is young, and patient says they have more pain when they get up in the bed. When they are early morning, when they are getting up with a stiffness and pain. Then initially we can do a test called isotope bone scan, where it can help you to delineate whether the disease is widely spread. They can have costochondritis, they can have sternoclavicular joint involvement, they can have enthesitis. And that's how you can evaluate further and treat accordingly.
Dr. Shabana, I have a few things to add as well as one or two questions to ask. Uh, First thing, what is exactly the role of ultrasound here?
Ultrasound, especially when there is enthesitis, when there is bursitis and all, to see the synovial thickening. Uh,
Okay, what happens? I'll just tell you. It can work in two ways. First thing is, if the patient is a known case of spondyloarthropathies, and you know the patient is having complaining of pain in some region, you can use the ultrasound instead of going for radiation like a CT scan or MRI, something which will cost you or which will radiate you. Instead of that, you can use that locally, and you can just do an ultrasound and see whether there is bursitis or enthesitis. This is one thing. Second thing, how it can work is, suppose if the patient has come with a heel pain, Achilles pain, or some other region pain, you can do an ultrasound, and you can in turn suspect that there is some type of enthesitis, and you can actually give a clue to the sending or the referring physician that this can be some type of spondyloarthropathy. So you should always think in that way. So it's going to help both the ways. And second thing is, like, I was just making a point uh, about the psoriatic arthropathy. Will it affect the hip joint?
yes.
It affects. It affects. But when you see a similar osteoarthritis like picture in a young patient, you should always think psoriasis as one of the differential diagnoses, because this exactly looks like osteoarthritis, but only the thing is the patient will be very young, and this will progress very rapidly. So whenever you see something like that, immediately you should get a idea that, or you should get a plan that you should have to tell the clinician that this can be one of the DD. Okay. So these are some of the things we need to learn from looking at the X-rays or images. Because normally what happens is images talk to us, but we need to talk to them back. Okay. And about the readers you were talking about, I'll just tell one. This thing actually is given in book also, just for easy remembering for all the clinicians or the other people, audience who are sitting there or listening to us. It's like, if a patient cannot see, cannot pee, and is having a sore knee, this is a clue that it can be suffering from. The patient can be suffering from readers. Okay. And Dr. Sir, I have one question for you. Normally, while reporting MRI, maybe we're reporting 30, 40 MRIs, and we see that out of them, at least around 7 to 8 patients or 8 to 9 patients, lumbar spines, if I'm reporting, I see that there will be multiple, so many patients coming with multiple areas of corner hyperintensities, but SI joints will be normal. So, what should be the importance I should give it to such MRI?
Basically, it has to be clinically related. If the patient says like they have the pain in the back from cervical region or thoracic region or lumbar region, and the pain is of inflammatory type, like it is getting relieved with the activity and it is getting aggravated with the rest, then those patient needs to be evaluated for spondyloarthropathies. Patient may not always have uh, GI tract involvement, they may not have psoriasis, they may not have the neck pain and all, or they may not have peripheral arthritis. But if the patient has a pain which is typically of inflammatory nature, then definitely we need to rule out the spondyloarthropathies.
Okay. So basically, what happens with us is we'll not be able to interact with the patient. But suppose if we are seeing these things in the MRI, it's always better to mention, so that when the patient comes back to you, you have the liberty to examine the patient back, and you can always come back to the diagnosis we are
Yeah,
missing.
what I would advise is before performing any test for the patient, like radiological test, MRI or ultrasound, better to ask the physician, the referring physician, to give the history and what is the clinical provisional diagnosis. That will definitely help us to come to a conclusion. Otherwise, like you do the reporting and we are expecting something. Sometimes we expect the patient has a disc problem and with radiculopathy, but we find that the reporting they mention about the sacroiliac joint involvement also. So that's how our diagnosis changes. Our patient might have both the diseases concomitantly. They might be having the disc problem, they might be having the spondyloarthropathy, but in front of like if the discomfort is more with the radiculopathy, they may not complain you about the buttocks pains and all. So history is very important. I think you can ask for the copy of the patient's prescriptions or doctor's prescription where they might be writing the history and all, and that's how we can correlate. Even simple X-rays. When we see the X-rays in patients with psoriatic arthritis, you may not find anything on the X-ray hand when you compare with the rheumatoid arthritis. Rheumatoid, we typically look for periarticular osteopenia, but that will be missing in patients with psoriatic arthritis. And as you said, somebody is having DIP involvement, DIP joints involvement. DIP joints are involved predominantly in two conditions. One is a elderly person, that is degenerative joint disease, and second is inflammatory disease, psoriatic arthritis. And sometimes we find the patient who has erosive osteoarthritis involving DIPs and PIPs, they get labeled wrongly as either rheumatoid or psoriasis just because their ESR is slightly high or their rheumatoid factor is positive, which can be a normal phenomenon in elderly population. We quite find that 35% of the population after the age of 65, they are positive for rheumatoid factor, but they will be having erosive form of osteoarthritis where the DIP joints and you can see the seagull signs and all. The patients get treated even with biologics. That's what we have seen in the practice. Just because their RF factor is positive, they have erosive arthritis, they get treated with the biologics, which should be avoided. So it's a clinical history which definitely matters, and all the serological tests and other supportive investigation should be used as a supporting parameters rather than driving the treatment.
Thank you so much. Last question. So you have another 3 minutes time. I think one of my friend is also into the physiotherapy part, and he's maybe present in the audience. Can you just put few words on the treatment aspect and what are the disabilities that can arise from this type of seronegative arthropathies, and
Pardon?
how
What
to
are the?
manage? First thing is just can you tell a few words about the treatment part,
Yeah.
and secondly, what are the disabilities like what how it happens in rheumatoid arthritis? What are the disability percentage that can happen in the rheumatoid arthritis, and how to
Yeah.
manage them?
Right. Though the first treatment whenever we see the patient with spondyloarthropathy, the first thing we'll tell them is they should meet the physiotherapist first. It is not the like we will give the medicine for relieving the pain and all inflammation, but the first thing which I write is I write them physiotherapy. Go and meet the physiotherapist because they are the main people who are going to help them reduce their suffering, prevent the deformities. If the person is not doing physiotherapy, just taking anti-inflammatory drugs, and sitting in a very bad posture, they might have the bamboo spine just because they are sitting in that posture. So I tell them ki they need to get up very frequently. They should be very active and moving all their neck, their back, and all. So every 1 hour they should get up and do some 5 minutes stretching and all, so that we can prevent the deformities. Physiotherapy plays a very important role. The physiotherapist, when the patient goes to them, they take certain measurements. I send all my patients with like they need to have their chest expansion. They need to regularly monitor whether their chest expansion is coming down. And when the spinal cervical spine is getting fused, what happens is they start moving the uh, head forward. So the distance between the wall and the tragus of the ear it starts increasing. That tells you that the patient is further stooping forward. So all these small measurements, the wall to occiput, wall to tragus, forward bending, shoulder stress, then their lateral bending, how much the distance is covered and how much it is lost, the range of movement of the spine. These are all assessed by the physiotherapist. So physiotherapist it plays a major role in managing a patient with spondyloarthropathy. Then coming to the pharmacological management, we give them anti-inflammatory drugs. If the patients are not responding, if they have predominantly axial skeleton involvement, in addition to physiotherapy, anti-inflammatory drugs, then we have biologics which are called as anti-TNF therapy. Those are all injectable forms. But post COVID, in the last 2 3 years, we have now JAK kinase inhibitors, a new drug which has been launched, which is in the oral form called tofacitinib. Even tofacitinib can be used in treating the patients with spondyloarthropathy, and it is giving a very dramatic response, very fast response, and it is suiting to the patient's pocket because it doesn't cost much. Whereas biologics are very costly. Yeah, among the biologics, like we call them as anti-TNF agents, we have one drug called etanercept. The cost is around 7,000 rupees per week per injection. Then we have a injection called adalimumab, which is given once in 2 weeks. It costs around 15 to 20,000 rupees. Then we have third agent, which is called as infliximab. It is given at 0, 4, then 8, then every 2 months. It costs almost 80,000 to 1 lakh rupees. So the treatment is very costly. And patient might fail in spite of taking this treatment if they are not doing the exercises because they will have the fusion of their whole vertebral column. So their neck movements will get restricted. Their chest expansion will come down, so they won't be able to throw out or cough properly. So they'll be more prone to have respiratory tract infection. Then their forward bending will come down, and then might be entrapment of the nerves, which can lead to radiculopathy, radicular pain. Then their hip joints get fused, the range of movement get restricted. Then they won't be able to lead a normal life because they'll be able to walk very slowly because of the restricted hip joint movements. If the sacroiliac joints get fused, again they have the same problem. Their mobility will come down and their quality of life will become very bad.
Yeah.
So physiotherapy and exercise forms a important part of the patient's treatment. Sometimes patient can be managed just with simple physiotherapy and anti-inflammatory drugs without any need for biologics or costly medicines for years together. So they need to take out time for themselves. I tell all my patients, if you don't have time for yourself, then you are earning for us. You are sitting for hours together and you are making money, not for yourself. You are earning it to give it to us.
Yeah, yeah, exactly. Yeah. Since you also told about the chest expansion, I think this
Yeah.
chest expansion is because there are involvement of costosternal, then this sternocostal, all these ligaments.
Yeah, it is because of the inflammation of the costochondral junction. So they have
Yeah,
costochondritis.
that itself can be one of the diagnostic sign for the for the diagnosis of
Yes. And
oncology.
most of the time, patient might present with the cardiologist or gastroenterologist for cardiac evaluation and endoscopics. And
Exactly.
they fail to realize it could be simple ankylosing spondylitis.
Yeah. Thank you. Thank you so much, Doctor. I think we already overshot our time by 3.5 minutes. Thank you for sparing your time. I could
Pleasure,
see
sir.
you all the way driving in the car. Now, probably you reached your home. I can see your car stopped now. Okay. Yeah. Thank you so much once again from
Pleasure, sir. Pleasure, sir.
BBC side also. Thank you very much.
Yeah.
Thank you,
Thank
sir.
you very
Thank
much.
you for giving
Thank
us
you
more
very much.
information. Thank you, sir.